Hello, everyone. Hello, our attendees. Welcome. Good morning, good evening, and good afternoon for everyone from all over the world. Welcome to this webinar, Addressing and Understanding Overdiagnosis in Medicine. I would like to introduce our speaker, Dr. Ronald Wyatt, who is a renowned global healthcare quality and safety expert with a passion for advancing health equity worldwide. As a distinguished senior IHI fellow, he holds a pivotal roles as the Chief Science Officer and Chief Medical Officer at the Society to Improve Diagnosis in Medicine, a leading organization dedicated to enhancing diagnostic accuracy in healthcare. With a career spanning decades, Dr. White has emerged as a tireless champion for global health equity, tirelessly advocating for equal access to high quality healthcare services for all populations. His expertise extend across a wide spectrum of critical areas in healthcare, making him a multifaceted force for positive change in the industry. And today we invited Dr. Ronald to speak about addressing and understanding overdiagnosis in medicine, which aligns with also the movement of choosing wisely. Dr. Ronald, the mic is yours. Welcome.
Thank you, Ms. Nami, and thank you to all of you for allowing me to spend a bit of time today with you. So good morning, good evening, good afternoon, wherever you might be. So we have quite a bit to cover, and I want to go through this so that we can leave some time towards the end for possible discussion and questions. I have nothing to disclose, and let me remind everyone that I'm the Chief Science Officer and Chief Medical Officer for the Society to Improve Diagnosis in Medicine. And at what we call CITM, we work to foster inclusive systems, and we also work to promote equity and diagnostic excellence. The mission of CITM is to create a world where no patients are harmed by diagnostic error. The mission at CITM is to catalyze and lead change to improve diagnosis and eliminate harm in partnership with patients, families, the healthcare community, and every interested stakeholder. So let me just start by defining from the perspective of CITM what diagnostic error is, which is the failure to establish an accurate and timely examination of the patient's health problem or communicate the explanation to the patient. These are just some facts that really are, I know this is a global participation, but these are just data from the United States that begins to show us how big the problem is in the US, but also I think globally. And here, like globally, we focus on diagnostic error that is catastrophic, that is common, that is costly, and that it is also inequitable. Well, then when we think then about diagnostic accuracy, what we're talking about this as the sine qua non of high value healthcare. If the diagnosis is wrong, all else that follows, either harm or waste or both, contribute to the problem. So as a part of this presentation, what I'd like to do is focus around these four objectives: defining overdiagnosis, discuss the root causes and contributory factors involved in overdiagnosis, how to prevent overdiagnosis, and then to understand how overdiagnosis can lead to harm. Now, I think it's really critically important for all of us to understand that, as I described, diagnostic error and overdiagnosis, these are really two separate concepts, not to be confused. So as we go through this presentation, our focus will be on the concept of overdiagnosis and how that's defined. And what you see here really are I pulled three separate diagnoses. The one that quite frankly makes more sense to me and is clear is the third bullet point that does come from wiserhealthcare.org in Australia. When you get a diagnosis that causes more harm than good. I think that's a really clear, concise definition of overdiagnosis. There are others, as you see here, that it occurs in a population when conditions are diagnosed correctly, but the diagnosis produces unfavorable balance between benefits and harms. And then a more recent diagnosis from a colleague at Yale University here in the US is that it is a situation in which we find a disease that wouldn't have been clinically apparent if we hadn't gone looking for it. In other words, the person diagnosed never would have developed symptoms or died from the condition. So then when we think about overdiagnosis and ask ourselves the question then, why is overdiagnosis important? And you'll see here some bullets that go through that. First, as was described, it can lead to unnecessary treatment. It increases the cost of care for everyone. It also introduces an imbalance in how resources are distributed or allocated. It can also have a psychological impact on people and families and communities. There are also public health implications, and there can be ethical considerations around, are we overdiagnosing a person? And then I think critically important to overdiagnosis, and I'll pause and say, I practice internal medicine here in the United States for about 25 years. And the impact of trust becomes crucial when we think about all forms of diagnostic error, and that includes overdiagnosis. So then we move on and say, okay, what more can we talk about then in overdiagnosis as we go deeper into the topic? And the next couple of slides from the National Institute of Health, I think, provide some basis of what we're discussing. What is overdiagnosis? So when overdiagnosis occurs, and we're going to use here cancer as an example, when cancer is detected by screening, but it would not have been detected in the absence of screening. And when you look at the slide here, from clinical onset to screening for detection to some clinical diagnosis that happened without screening, and then a non-cancer related death occurs. And from this definition, then, this is not overdiagnosis. And pay close attention to the lead time in this next slide, same definition, but if you look at the lead time, you'll see a difference in lead time when a person is overdiagnosed between a non-cancer related death and a clinical diagnosis that would have occurred without screening. So you look at that lead time, and I'll go back and you see the difference in lead time between not overdiagnosed and overdiagnosed. Well, then what does overdiagnosis depend on when you think about that depiction? You look at that unobserved lead time that I talked about, and you also have to consider the risk of other causes of death. Overdiagnosis tends to occur when the lead time, as I talked about, is longer than the time to the cause of death. And then if we think about making the correct diagnosis, overdiagnosis is more likely, based on data and evidence, overdiagnosis is more likely to occur when the person is older or when the disease is slow growing or not progressive. Another example of this, and you see this animation of the same person in two different scenarios. She comes in and has developed a small, slow-growing breast cancer in her 50s and 60s. So if you look at those two scenarios, you see what could happen. One, Maria has a screening. She's diagnosed. She undergoes treatment, and she lives until she's 85 and dies from heart disease. In scenario two, Maria doesn't have screening. There's no cancer diagnosis or treatment. Her cancer is never found and never affects her health. And then in the end result, Maria lives to age 85 and dies from some other heart disease. Now, again, a very linear, simplistic view of an example of overdiagnosis. And we all know that real life is not that linear, but it just gives you an idea about what can happen if a disease is overdiagnosed. The same applies, but not the same to overtreatment and overdiagnosis. So then if you look at a worst case scenario and think about some new or emergent diagnostic test or technology, and how it's promoted, especially to asymptomatic people. And I dare say here in the U.S. at least, we can see television adverts that promote some new testing. Well, then what that can potentially lead to is more people being tested and diagnosed as a risk. And then what happens, a person becomes labeled to be at risk for a disease. More people are treated. And then downstream from that, what we find is the impact in a psychosocial way, the anxiety that it results from this overdiagnosis. The incidence of a disease is impacted. Cost increase. There's an opportunity cost associated also with a process like this. And again, the iatrogenic or healthcare introduced physical harms because of a treatment that could have some other complications. So then, if we understand those concepts, then let's talk about just 3 points of what overdiagnosis is not. Again, I'll refer back to my original slide by saying that diagnostic error and overdiagnosis are separate concepts. But here we talk about what overdiagnosis is not. It is not over-testing. It is not over-treatment. And then for those that are familiar with the epidemiology, the concepts of a false positive result, a false positive result does not necessarily equate to an overdiagnosis. Here's a more recent clinical practice guideline, just as an example. And this is, as we say, kind of hot off the presses, a practice guideline that says, here's the role of biomarkers for the management of Crohn's disease. And what this guideline is saying now, that if we use a biomarker, that could potentially decrease the number of people that need to or have to or actually do undergo colonoscopies. So if we then think about practice guidelines and new testing and new techniques and new technology, like the use of biomarkers, we also have to consider, when you're following a guideline, what are the potentials in following a guideline that's evidence-based that can potentially lead to overdiagnosis. And then when we think about what are the causes of overdiagnosis, it occurs at multiple levels. So we have to consider that overdiagnosis is a significant problem. We don't know if it's intractable or not, but we need to think about some approach that can address this issue. And it has to be a multi-level approach. This includes research and education at the population level. It includes precise and precision screening for people at high risk for a particular disease, like the example with Maria and breast cancer. We have to think about what are the incentives and what are the feedback systems in place that need attention. This includes, particularly here in the U.S., the medical malpractice litigation and financial incentives that can come into play. We have to think about then positive feedback from patients that say, thank you for saving my life. And this is a person that maybe had a misdiagnosis, versus no feedback in patients who potentially were overdiagnosed. So the mantra becomes, all cancers, for example, are life-threatening, and when in doubt, cut it out, which is we've heard that before. So that can be an overdiagnosis that leads to some of the harm that we talked about, and how we need to begin to address overdiagnosis in a more significant way, because overdiagnosis does and can lead to harm, as we talked about. A part of that harm is physical and mental health, of undergoing repeated tests or repeated procedures for a diagnosis that may or may not be there, for a diagnosis that may or may not save your life, when you could potentially live a longer life and die of some other disease other than, for example, cancer. What are the economic factors for people, for communities, for healthcare systems that need to be considered? And then if we look inside, particularly in the U.S., what we call value-based purchasing, think about, is overdiagnosis effective and efficient inside of a system? And then what is the experience of the patient who goes through the process of what turns out to be an overdiagnosis, and how we begin to understand that overdiagnosis uses resources that are valuable. Again, it leads to increased costs for everyone. It requires additional professional time from caregivers trying to understand and decide what to do when there is overdiagnosis. So that becomes potentially the time spent by nurses, by doctors, by other staff that could be spent treating patients who actually have health problems. The misallocation of professional time really diminishes the efficiency and effectiveness of the healthcare system. And again, think about the patient time and the emotional impact of overdiagnosis, of unwarranted procedures, of emotional fallout of a false diagnosis, the downstream anxiety, the stress, other psychological effects as patients begin to process this information about a disease that they actually do not have. That leads to a further deterioration or the decay of trust between patients and the healthcare system. When patients are subjected to unnecessary medical interventions, their confidence in the healthcare system and ability to the healthcare system ability to make a diagnosis diminishes that trust. In the U.S. and other places, it can also increase insurance costs. It relates back to the concept of overutilization of services due to overdiagnosis. This affects all of us. It impacts many who never experienced even an overdiagnosis. And then we talked about opportunity costs. This is the resources, the time, the money spent on overdiagnosis that could be used on preventive healthcare measures, education, treatment for the underdiagnosed or untreated conditions. The opportunity costs then represent a significant loss in potential health benefits at the population level. So then if we think about mitigation of overdiagnosis, I put a few bullets here. As we mentioned earlier, how we began to use truly evidence-based guidelines. We need to look at and refine diagnostic criteria, improve communications with people being served, patients, engaging patients and families in the concept of shared decision-making, providing education and training of clinicians. This includes clinicians in training, and then recognizing that we need to revise, refine, innovate policies and systems and change them. One of these, particularly in the U.S., is around payment as a means of mitigation. So then we talked about in the objectives, what are some ways that this can be prevented? And I know this is a big list, but everything on here I think becomes important inside of a system as we think about is overdiagnosis leading to ineffectiveness and inefficiency and harm inside of a system. So if we start then these 10, a lot I'm sure, but all important. We need to think about enhanced medical training education, as I mentioned, begin public awareness and professional awareness campaigns about this issue. As I talked about, what is the role of healthcare policy and regulation? How do we audit and review medical practices? And frankly, this also includes root cause analysis when there has been some unanticipated less than optimal outcome. How does technological advances either contribute or not to overdiagnosis? Those need to be carefully looked at. Are we complying with the development of and adherence to clinical guidelines? I mentioned earlier shared decision making. How are screening programs being run? Are they being evaluated and assessed to make sure that screening programs aren't creating, as we talked about, increased incidence of a disease that leads to unwarranted treatment? Then making sure through some type of audit overview structure, if the appropriate diagnostic criteria is in fact being utilized, and again, ongoing research and evidence around practice to make sure that we are coming up with the best evidence to apply to preventing overdiagnosis. And now, since we're in the age of artificial intelligence, and we can say that artificial intelligence will continue to evolve. So then leveraging technology and artificial intelligence to assist in more accurate diagnosis will play a critical role in addressing not just overdiagnosis, but diagnostic error in medicine. The technological tools, including AI, that can be used to analyze complex data and provide the much needed decision support for those of us who are involved in diagnosing patients. So I'll end and hopefully have some questions and discussion about what I would just call a call to action around overdiagnosis. So let's reiterate that overdiagnosis is a practice of diagnosing a condition that would not have caused harm poses significant patient safety issues. It can lead to unnecessary treatment, psychological distress, increased costs, waste of healthcare resources. It can be driven by a combination of factors, including the use of sensitive diagnostic tools, patient and physician attitudes toward disease prevention, and healthcare systems that may incentivize even extensive testing. So the call to action from my perspective then for our profession is education of healthcare professionals and students around the issue of overdiagnosis and the application and focus on evidence-based medicine, the appropriate use of diagnostic criteria, and patient-centered care, empowering patients with information. Patient education initiatives need to be bolstered to raise awareness about the potential harms of overdiagnosis. Patients should be encouraged to engage in open conversation and dialogue with healthcare providers about the necessity and potential outcomes of diagnostic tests and treatments. The adoption of clinical-based guidelines should be regularly updated to the latest research to ensure they reflect the best practices, promote shared decision-making that includes patients' values and preferences and the best available evidence, reform healthcare policies and advocate for policy changes. This involves shifting, like we are in the US, towards value-based models that reward quality of care over quantity of procedures being performed, and then support ongoing research, fund ongoing research that should be aimed at improving diagnostic criteria, developing better screening methods, and understanding patient-physician behaviors to contribute to overdiagnosis. Regular audits and feedback are crucial inside of healthcare institutions. That way we can provide feedback to clinical decision makers based on the audits to help rectify practices that lead to overdiagnosis. And then organization individuals need to engage in awareness campaigns that highlight this issue as a patient safety concern. The campaign should take the form of what we're doing today: seminars, workshops, social media campaigns, other collaborative efforts with patient advocacy groups as we work closely with at the Society to Improve Diagnosis in Medicine. By taking these actions, then, we can collectively work towards reducing overdiagnosis, safeguarding patient health, optimizing the use of healthcare resources, and ensuring that medical interventions are truly beneficial to patients and to systems. And there I will stop for questions and discussion and say thank you very much. Appreciate the time.
Thank you so much, Dr. Ronald. I would like to thank you for this amazing presentation because it touched me on a personal level and on professional level, because I work in the Saudi Patient Safety Center, and all we aim for is to prevent harm from happening to the patients and also for healthcare providers. And overdiagnosis was our theme in our last year conference, which was in 2022. The theme was overdiagnosis and preventing the overdiagnosis. And this is how important overdiagnosis is for us. And on the other hand, which is the misuse and the overuse of some testings and medication requests for patients that is unnecessary and unneeded for patients. So we work on every project that is aiming to prevent harm to patients and for all. So that's why we have one of the most important initiatives that started actually in the United States, which is Choosing Wisely. And after its success, it spread all over the world. And just since 2019, it started in Saudi Arabia by the lead of our leader, Dr. Aisha, which is attending this webinar today with us. So the Choosing Wisely is aiming to prevent all unnecessary care or unnecessary tests and requests to the patient that might cause harm for the patient. So I just wanted to give this introduction because I want to say that I loved your presentation. It is to the point, and it covered all the aspects of what we are trying to work on. However, we have some questions from our audience here. One of them is Dr. Reem. She said, if we try not to subject the patient to unnecessary tests and medication, how do we avoid malpractice and lawsuits if the patient later finds out that we didn't treat their condition due to underdiagnosis?
Right. So I included just a blurb around medical malpractice and litigation, and I emphasize making sure that you're following clinical guidelines and evidence-based best practice. And by background, I served as the patient safety officer for one of the biggest medical malpractice companies in the United States. And one of the things that we repeatedly saw in the scenario, Ms. Lamia, that was just described, is lack of documentation. So in the process of making a clinical decision with people, families, patients, making sure that your documentation supports the decision. If that documentation is not there, then that is a risk, and it opens you up to potential litigation if you don't document, and that includes documenting the evidence base that was used to make that decision, documenting that I had this conversation with the patient and I shared with them the evidence, making sure that documentation is there. So as we always say, if you did not document it, it was not done. So that would be my biggest piece of advice coming straight from the med mal industry here in the U.S. Most often there is a settlement with people because the documentation was either absent, it was inaccurate, it was incomplete. So that's the one thing that we can all do. Always fall back on what is the best clinical evidence. Did you use the clinical guidelines within your organization? If there's not a clinical guideline for a particular diagnosis, then that's when I talk about making sure that you are working through redesigning your clinical guidelines to meet current practice.
Exactly. And if I may add one more point, which is leadership engagement from early stage. For example, one of the main concerns when we started this campaign, which is Choosing Wisely campaign to prevent overdiagnosis and overprescription and over requests, unnecessary requests, was we are afraid of the patient complaints and how can we prevent that from happening. So what we did is we did not stop this action. What we did is we engaged the call center from our Ministry of Health, and we engaged them in the concept of choosing wisely as an initiative. And they, after many sessions of explanation to the initiative, they were engaged and they were adapting the concept, and they understood what was behind this initiative and what was it based on. So I think my point is leadership engagement or system engagement in general, and basing your decisions based, as you said, Doctor, based on the guidelines or clinical guidelines that is in your country.
Right.
One other question we have is from the same person, Dr. Reem. She's saying, I'm trying to find the question. Please write your questions in the Q&A, not in the chat, so I can find it easier. So how do we convince the patient that they don't need more testing or medication if they insist?
Yeah. So inside of the presentation is one critical aspect of patient-clinician interaction, that is trust. So building a trust in that relationship becomes crucial. Again, that's why I mentioned in 25 years of practice, the most important thing to me, two things. One was building a trusting relationship with people, and practicing humility, listening to people, and then making sure that their perspective is included in your decision making. Then that's when you share the evidence, and you share both sides of making a diagnosis that may be overdiagnosis, explaining as you mentioned, a particular medicine. And it wasn't uncommon for people to come in and say, I want to be on this particular medicine because this is what I think I have. So knowing the medication, being able to explain the risk and benefits of a medication for a diagnosis that maybe doesn't exist, that is a harm. Then sitting with the patient saying, if we put you through this, that I believe based on evidence we shouldn't, this is what can happen. It will increase costs, especially in the U.S. when a particular procedure may not be covered by insurance, that it may cause harm in and of itself. So for instance, if you get a CAT scan or MRI with contrast and have an allergic reaction, and turns out you never needed it. So making sure that people understand the risk and benefits of a particular intervention, a use of a technology, or even a treatment, which includes, should I go for some type of biopsy? And there I use thyroid biopsy because thyroid disease, cancer is one of those things that tend to be overdiagnosed. Do I want to put a person through a potential thyroid biopsy that can cause harm if it's truly unnecessary? So explaining to people what the treatment would look like, what is involved in further testing that can do harm to people. So making sure that all of that, again, is documented, that you had those conversations. Now, I will just say, you're not going to please everyone. And there have been times, and this is an ethical consideration that I mentioned. If a person insists on having a particular test or procedure, then as a physician, and I'm just speaking for myself, there are times when I had to say that that is not morally correct, and I will not do it. And then a person has said to me more than once, quote unquote, then I'll find another doctor who will. And that becomes that person's decision, not my decision. If I've laid out, the best evidence I have for why I think a decision should be made by that person, and that person decides on another decision, I document it. And if they decide to
Exactly.
go to someone else, then that's not anything I can do about that.
Exactly, exactly. Another question we have from Christopher, which is in some hospital, they are doing blood tests because they need to generate income and
Right.
ordered by the management. How can we prevent or stop unnecessary tests in this case?
Right. So I'm going to go back to your point, which is, I'm going to say, maybe the most crucial point in this, and I'll press by saying, I was the patient safety officer at the Joint Commission here in the U.S., and the leading root cause of sentinel events was lack of leadership. And in this presentation, I think leadership's become crucial. Next is having some system of audit to make sure that there is not perverse incentives in ordering blood tests and other diagnostics. And we've come across cases where in the U.S. where clinicians were ordering tests because they were getting some kickback from ordering these tests. So leadership with a robust audit mechanism should be able to stratify by a clinician and determine, why is this person ordering, for instance, more vitamin D levels than that cohort. And what I dealt with in practice here in the U.S. was a quarterly printout from Blue Cross. I'm in Alabama, so Blue Cross of Alabama, that would show me where I stood compared to other internists that had similar practices, and they can identify an outlier. So, for instance, if I were ordering more vitamin D levels than other internists, then there was a question raised about, why are you ordering those tests? And there have been in the U.S. court cases where clinicians, physicians were in fact taking kickbacks from lab companies for over ordering tests. It is a real thing. It's embedded in the presentation, the financial incentives, and how leadership and governance and audits can play a significant role in decreasing the over testing of people. That, in fact, is a harm. If you put a needle in someone's arm to draw blood that's not necessary, that is a harm.
You know what? One of the most challenges, maybe here in Saudi Arabia or maybe in other countries, is the when the care provided is free of charge and it is governmental and it is coverage, full coverage. They usually
Right.
patient tend to request anything, so they always use the phrase of it's free, so please request it for me. I want all of
Yep.
the tests. I want
Right.
a full
Right.
test, even if they did it
Right.
6 months ago or just 1 year ago
Right.
and everything is fine. So this
Right.
is the most, I think, challenging thing for healthcare providers is the dealing with patients that are unaware of the harm that this overdiagnosis can cause them. So yeah.
Yeah.
I would like also to ask you, Doctor, to elaborate more about what you meant by saying overdiagnosis is not overtesting and is not overtreatment. So what do you mean
Yeah.
by that, if you
Yeah.
can?
So again, if you go back to those definitions, I'll slide back through. Um, Yeah. So if you look back at the original definition, those three that we used, then it doesn't mention over. We just finished a discussion about over testing. So you can provide a battery of tests, for instance, because a person said what you just said. I'm in a system. It's quote unquote free. The fact is, it's not free because it's being paid for somewhere by someone, by all of us. So if I decide that I'm going to do batteries of tests on people because the person asked or because of my own non-evidence-based ideas, then I'm over testing. And then if I get back an abnormal result and there's not a clinical symptom that connects to that, then what do I do next? Now I'm going to order more tests because I have this abnormal test result that I can't explain that may or may not have had anything to do with a clinical symptom that the person had. So one test is abnormal, leads to another test, and could potentially then lead to some procedure or treatment that was never warranted in the first place. So that's over testing that leads into over treatment then. So if I decide, okay, I can't explain these abnormal test results, but they exist, so I'm going to go ahead and treat what I think is happening. That is not a diagnosis. So now you overtreat. If I back to a wonderful point you made, is I'm going to now give a person a medication that they might not need. There is no such thing as a medication that does not have a risk. There's no such thing as a medication that cannot cause harm. There's no such thing as a medication that is free. So now you're overtreating for something that never should have been treated. And then if we think about, if there are epidemiologists, clinical epidemiologists on the line, they know, false positive, false negatives, true positive, true negatives. If there's a false positive test, then am I obligated at that point to look for some other reason for it that could potentially then lead to overdiagnosis? But the false positive result in and of itself is not overdiagnosis. Now I got to understand, is this test result a false positive? And I'll give you a real life example from my uncle, who is in a hospital as we speak in the U.S. He is a physician. He's undergoing a total hip replacement after a fall related to COVID that happened last week. I talked with him 2 days ago. When he came into the hospital, he complained a bit of shortness of breath that he attributed to the fact that he had COVID. Well, it turns out that his D dimer was 19,000 on the US scale. So just by having a 19,000 D dimer, he had to undergo additional tests to make sure he did not have a pulmonary embolism. And he did not. It was not a perfusion scan. He had another CT angiogram. Think about that, based on a D dimer. And when you look at the literature, back to evidence, and he even said this, and he's an obstetrician. He said, I think it's just a false positive test that they're chasing, because the D dimer says you have an embolism. So he undergoes a CT angiogram. It was negative. Next, he undergoes pelvic and lower extremity ultrasounds with Doppler, looking for potential deep venous thromboembolism, thrombus, also negative. So he underwent these series of tests that caused him anxiety, could have caused additional harm, trying to look for something and a reaction to a false positive test for what someone thought was venous thromboembolism, just as an example, right? So those are just kind of explanations. We could spend a day just on these three things. I hope that helps.
Yeah, it helps so much. So overdiagnosis is not only doing tests, so many tests. It's about sequence of requirements for the patient based on his condition or based on the findings that for each patient. So it's a series of requests, not only tests. Even sometimes it requires other treatments or interventions. We have here a comment or a statement from our one of the attendees. and they would like to hear your comments on it. Thanks for your presentation. People always think harm is a physical harm. They do not think about the psychological harm, which is more common as a result of overtesting. In my practice, I have seen many unnecessary referral to specialized clinic because of this practice. And you don't imagine the psychological stress these patients have, especially if they are referred to highly specialized clinic, and some of these tests done because of patient or family request and sometime from physicians. Please, your comments.
Well, I mean, that's the comment. I agree. And I can
Yes.
tell you in my years of practice, more than a few times, people have said, I went to a person, a specialist, that want to do a particular procedure or test, and I'm nervous about it. They didn't explain to me even why they want to do the test or why they want to do the procedure. I need to understand. And I can say these words because they were said to me so many times in practice. I need to come and talk to you because I trust you. So I go back to trust in these relationships. And I would say, come in, let's talk about it. All right. Now, the other thing that patients would say to me is, do you, Dr. Wyatt, trust that physician that told me I needed this test? Right. And if you don't trust them, why should I? So please send me to someone that you trust. Right. That's that trust in that relationship that we need to have. And I've had, again, really frank, intense fellowship, I'll put it that way, with patients and families because they've decided that because of a TV advert or from a friend or someone else, that here's a particular test or procedure that they need. I also practice medicine in a place that was highly educated, Huntsville, Alabama, which is a town full of rocket scientists, a high-tech town. So it was not uncommon for rocket scientists, engineers to come in because they've decided here is something that I need done. And we have those conversations and I explain based on scientific evidence and best practice, the answer is no. And then that, again, I feed straight back into ethical decision then. Am I going to do the test that I know is not necessary because this person is sitting here, I'm a rocket scientist, I know what I need. And again, if you don't do it, then I'll just find someone that will. You have to have the moral attitude to say, then that's what you'll have to do. And I'll, again, be very frank with the audience. There's more than one time I've said to people, I do not think you need this test. Here are my reasons why. I'm going to document this conversation with you, back to documentation. And then I finish in a kind of cynical way, which I shouldn't say, but I will. I will just say to people, I'm just not smart enough for you. So you will need to find a physician smarter than me.
Yeah.
Thank you.
And this decision have been made for you. It's not against you. So this is the
Right.
most important thing. Yeah. And we have also a question here from Abdurrahim saying, please explain the difference between overdiagnosis and trying to prevent or early detect a certain diseases.
Yeah. I'll try to answer that question as best I can. That's a really difficult question, challenging question, and it's why I go back to this particular slide. As clinical decision makers, when you think about how did this person present to me, as you look at this slide, is there some preclinical symptom, preclinical disease? I have then got to decide, is some type of screening warranted? Based on that person's presentation, based on scientific evidence, and I have to be able at that moment to apply concepts like what is positive and negative predictive value. You have to understand those things. And what's the positive predictive value? What's the negative predictive value? And you know that underneath that is false positives, false negatives, etc. So now you're in that screen detection mode, and you're in a lead time now to either make a diagnosis or not make a diagnosis. If I decide based on clinical presentation, based on the evidence I've garnered from the patient in history and a thorough, I repeat, a thorough, and I will say for the third time, a thorough physical examination, then I can have that conversation with the person saying, based on the exam, your history, the evidence, we don't need to do any other testing right now. We can have period of time when I will see you on a continuous basis, and then I need you to let me know if any new symptoms or findings happen. And then we can revisit, do we need to do any additional screening or detection methods at that point? And then if at some point in that lead time, if I say, okay, I think based on what you're saying, we now need to proceed to some type of screening. And then we can have that discussion about the type of screening, what the screening is going to find, what's the risk and benefit of the screening. That could be an invasive test. It could be an invasive test. But I'll go back to your previous question. And now, if I say to that same person who thought they needed that test, and I say, okay, now we got to do some additional testing, then still you have the anxiety to deal with. Because they're going to go and say, oh, the Dr. Wise said I need this test now, and I didn't know if I needed it. Now he's saying I need it. I know there's something wrong with me, and I'm going to die. I've had those episodes. So think about all of that in that lead time and be able to explain why now. Why now do we need to do this screening test? And then if it's positive, what we do next. If it's not positive, then what we need to do if it's not positive. That doesn't mean you just wipe your hands of it. You say, okay, the screening test that was the best screening test available, the gold standard test that we did, that doesn't mean I'm just going to forget it at this point, because something else may emerge and a disease may, as we say in internal medicine, a disease may declare itself at some point. And then we can go back through that process. So that's when you're in that lead time and you follow that patient on out as a part of I would say, the way we need to practice medicine. I hope that helped.
Yeah, exactly. You explained very well, Doctor. So we have also another question from Bassam Al-Ka'bi, who's saying, how can clinical documentation improvement programs prevent overdiagnosis in the setting of looking for more required specificity that justify the length of stay? I'm not sure if the question is clear.
So it sounds like it's a question around length of stay.
Yes. So how
Yeah.
can the clinical documentation improvement programs prevent the overdiagnosis in the setting of looking for more required specificity that justify the length of stay?
So I'm going to, so documentation becomes crucial to length of stay. And there are many systems here in the U.S. that are struggling with the issue of length of stay. And to the questioner, it does come back to what have you documented? It's not going to be enough to say to a utilization review person, I think this is what's going on. And they look at the chart and say, well, you haven't documented any of that. So therefore, this person, you need to start planning for them to leave the hospital. So it goes back to documentation, why this person is still here. Again, what's the evidence of this person still being here? And what are my interventions right now? Do I have any additional testing that needs to be done? Can that testing be done in an ambulatory outpatient setting or not? And there are a lot of considerations in that even. You may have a person that lives in a remote area that it will be difficult for them to come back in for testing. So you have to consider that part of it. Like in the US, it may be a rural area and a person may live 60, 80 miles away or 100 miles away. So that can contribute to your length of stay if you can't get those interventions properly scheduled and completed, and then feel safely that this person now can leave the inpatient setting. So that gets back to, in this presentation, what's happening around audits and how are audits being measured and what's contributing to length of stay. Let me say it a different way, and I'll use IHI terminology. What is the primary drivers of the increased length of stay? Is a delay in diagnostic testing? Is it taking too long to get a CAT scan or MRI because we only have two? One MRI unit is down. Now we only have one. So the time to get an MRI has doubled or tripled. Now, is this person clinically stable enough to leave the hospital and come back for the MRI? So you can see now how that becomes a very complex and complicated process. And everything I said now, again, should be documented. This person lives 80 miles away. They need an MRI. The MRI is down. the one MRI, they can't do it until 2 nights from now. This is my justification for this person's continuing to stay in the hospital setting. So you have to understand the setting and what's contributing to it, what's driving it, and then what can your interventions be in an effective, and this is in the presentation, an effective and an efficient manner.
Yes, thank you. So, Doctor, I was surprised that we have a lot of attendees today, over
Yes, you
300
do.
attendees. Yeah, that's good. And we have a lot of questions running. Some of them are repeated, so I skipped some of them. But one of our attendees is from the patient societies. So they were asking, how can patients help, or what can patients or patient representative, or what we call them, the caregivers, can help in preventing overdiagnosis or overuse of any kind of either testing or medication or treatment or intervention. So what can the patient societies do, and what can the individuals as patients or their caregivers or their families can do to
Right.
prevent that?
Right. So let me just first just kind of give some kudos to SIDM, Society to Improve Diagnosis in Medicine, where we actively try to engage with patients and families. So my first question in any system first is, do you have a patient and family advisory council? Next question, how is the patient family advisory council being used in your system? What does that look like? Next, have you thought about, which is in the presentation, setting up some type of shared decision-making process? And you can look at what was set up by Marjorie Godfrey at Dartmouth years ago, how you set up a true shared decision-making system. I would highly encourage systems to truly not just start a shared decision-making process, but to measure it. How is it working? What's the impact of it? How are you assessing it? And is it working for you? So two things: have a patient and family advisory council. Number two, have some type of shared decision-making process.
That's perfect. If I would like to add more, as I was the patient empowerment head section previously in the Saudi Patient Safety Center, I would also add that asking patient to ask questions. So if a lot of us just go to the pharmacy and then take a number, when we receive the medication or when we go to the lab, we just realize that the healthcare provider just requested a bunch of things that I don't need, and I know because I was empowered and I was knowledgeable enough to know that I don't need those kind of things or these kind of tests. So I would also add to what you said, doctor, is to ask a question or encourage the patients and the caregivers and the family representative to ask questions to the healthcare provider and act as partners in the decision making process to choose the correct request or intervention for them. uh, uh, so we are 5 minutes away from our at the end of our webinar, and I would like to take one more question, which is, so what is, if you would recommend, what is the number one solution when if you are a frontliner, you are a healthcare provider, you're not a decision maker, you're not a leader, or you're not a stakeholder, what can you do as a healthcare provider to prevent overdiagnosis, or what is the number one prevention methodology to prevent overdiagnosis from your point of view? So you talked about mitigating the overdiagnosis, and also, as you showed in this slide, preventing overdiagnosis. But what is the number one from your expertise is the thing that you can send as a message to our healthcare providers in this webinar?
Yeah. So thank you for that question. When I was finishing training in internal medicine, older physician, experienced physician, gave me some advice. The first piece of advice to answer the question was, when people come to see us, listen. Listen to what people say, and then use your clinical skills. That includes a comprehensive history and physical examination, bring in with the permission of the patient, the family's voice to understand family dynamics. So listen, do a complete history and physical exam, then construct a working list of potential diagnosis, what we call differential diagnosis. Use your clinical skills and scientific training to decide with that patient and family what's the best approach to take in terms of follow-up steps of testing and interventions. Explain them to the patient and family, document them, and continue to meet with patients and their families in case there was some symptom or sign that was missed, that you can go back and try to complete the story, and not go off. We use some Occam's razor. Typically in internal medicine, we can explain a person's presentation and symptoms with one disease, not 5 or 6. So you look for what will unify the patient's presentation that will guide you to apply with their partnership the right types of follow-up testing to perform in order to come to some unified diagnosis that can explain most of a person's presentation.
So as they always say, enrich the conversation between you and your patient, and also encourage the patient to have a shared decision between their healthcare provider and themselves. Thank you for this closing remarks, Doctor, and I appreciate you being here with us. And we are really keen to learn from the United States in a lot of aspects related to overdiagnosis and preventing overdiagnosis, and also in choosing wisely as a concept in general. Thank you very much, and hope to see you in our next webinars. Appreciate you being there. Thank you.
Thank you. Alhamdulillah.
Thank you.
Thank you.
See you everyone in our upcoming webinars. Thank you very much. Good night, and have a nice day.